Hello, dear friends. Today we will discuss about insulin regimes and the learning objectives of the today's session are students should know the required units of insulin to control the blood sugar level, both basal blood sugar level as well as postprandial blood sugar level. Then rationale of using the combination of different insulin preparations, that we call it as a insulin regimes. Then what are the advantages and limitations of each insulin regime? So these all we will discuss in this class. Now, what is the insulin requirement on an average in the diabetic patients? In type 1 diabetes, the insulin requirement is around 0.4 to 0.8 units per kg per day. Now, one has to be very precise, and that's why here the dose has been mentioned in per kg. But again, dear friends, this is a general average requirement. There will be definitely case to case variation, and even in the same individual at a different time the requirement may be different. There are many conditions that we will see in the next subsequent slides in which the requirement of the insulin increases. In the type 2 diabetes, the range is even wider, 0.2 to 1.6 units per kg per day. Now, what is the requirement of insulin? Primarily, the insulin is required to control the basal blood sugar level. 24 hours basal blood sugar level, which controls the hepatic glucose output, and second is control the postprandial, the meal related hyperglycemia. These are the two principal functions that the insulin should subserve in each diabetic patient to control the blood sugar level. Now, this requirement depends on many factors, and first and foremost is diet, the type of the food that patient consumes, the time at which the patient consumes the food, the amount of the food, the quality of the food, physical activity, the site of the injection, because the change in the site of the injection as well as the depth of the injection, it will also affects the absorption, and because of this the requirement of the insulin and blood sugar control, and there are many more factors. So to control the blood sugar level is a very complex task in a diabetic individual. Now, just we look at briefly an overview of the availability of different insulin preparations. Now, there are many ways of discussing the insulin preparations, but here we focus because we want to discuss the insulin regimes, and that's why we see the insulin preparation in relation to the onset, the peak, and the duration. And according to that, the most rapidly acting insulin is ultra short acting, and these are insulin analogs lispro, aspart and glulysin. Their onset of action is less than 30 minutes. In many cases, with some preparations, it is around 10 to 15 minutes also there. While the peak is around 30 to 90 minutes and duration ranges from 2 to 6 hours. It is followed by a short acting or the regular insulin. Here the onset is 30 to 60 minutes, which is the main drawback in terms of if you it is a short acting insulin which was previously used to control the postprandial hyperglycemia, but to control this one has to take the regular insulin 1 hour before the meal, and it is very cumbersome and the patient compliance is less. The reason is that once the patient has taken the regular insulin, he or she has to take a fixed quantity of food after a fixed interval, that is 1 hour. Then the peak is around 2 to 3 hours. Again we require a somewhat early peak to control the postprandial hyperglycemia, and duration is around 8 hours. While by adding the impurities like zinc and protamine can produce intermediate insulin like lente and isofen, the duration onset of action is 2 to 4 hours. Peak is around 4 to 10 hours and duration is around 18 to 24 hours. And the last is insulin analogs, that are long acting insulin analogs, that are glargine, detamir and degludec. Onset of action is same as like that of intermediate acting insulin, this is 2 to 4 hours. Peak, what is the meaning of dash? It means there is a no peak. Yes, exactly. The glargine is having, I will show you in the slide also, in the graph, that glargine is having a no peak. It is having a peakless effect. And it is very obvious that the chances of hypoglycemia with the insulin preparation is maximum at its peak, and that's why with the peakless glargine the chances of hypoglycemia is very less, while the duration is 24 hours. Now the same we can see in this figure. Here you can see the peak, that is early and more defined peak in ultra rapid insulin, that are insulin analogs lispro, aspart and lolaisin, followed by a shorter acting somewhat delayed peak but definitely higher peak as compared to the NPH, and definitely early as compared to the NPH and lente. While in case of NPH and lente, there is a slow absorption and the peak is delayed. While if you just look at the glargine, you can see a flat line. There is a no peak. Okay? Now, if you just summarize this, and if you just club all these points, and at the same time, if you just think about our normal physiological release of the insulin pattern and that insulin pattern in relation to our ingestion of the food. Now, can you think that any preparation, any single insulin preparation, it can control a 24-hour blood sugar level? Even the answer will be definitely no. Then if you think about whatever will be the preparation, or if you are giving 2 preparations or 3 preparations, but in a single daily dose to improve the patient compliance, nothing else, but still it can serve its purpose, the answer will be No. The reason is that we have to control the meal related hyperglycemia without producing interdigestive hypoglycemia, and at the same time we have to control the basal glucose output that occurs from the liver. So we have to control the basal blood sugar level also. And the most common problem is if you tightly control the postprandial hyperglycemia, there are chances of development of interdigestive hypoglycemia. Okay, so we will see in the next slide how we deal with. One thing is very clear that the normal physiological release of the insulin, it cannot be mimicked by any preparations or any combinations or any regime. But our aim is to try to reach up to the level of the insulin in the plasma which can manage the blood sugar level up to a satisfactory level. And that's why the aim of the physician in a diabetic patient is not to achieve the optimum fasting and postprandial blood sugar level, but the aim is to achieve the FBS around 110 or 120 and ppbs at around 150. And the reason is that if you tightly control the tightly control the blood sugar level, the chances of development of hypoglycemia will be very high and it is very dangerous. So now if we just see that this is a on x-axis there is a time and on the y-axis there is a concentration of the insulin in the plasma, and these are the I have just covered the 24-hour period from morning 6 to next day morning 6. Now can you see that, or can anyone tell that what this arrow indicates? At morning 8 a.m., at noon 1 p.m. and at evening 8 p.m. These are the timings of our breakfast, lunch and dinner. So obviously during this time or after the breakfast, after 30 minutes to say for example 45 minutes, the blood sugar level rises and it reaches its peak. So we have to control this post meal hyperglycemia, and for that, suppose we are giving, as we all know that the regular insulin, it requires 30 to 60 minutes for the onset of the action, and that's why we are giving regular insulin. Here you can see in the figure we are giving regular insulin around 1 hour before the breakfast. Then what it will do? It will definitely cover the post meal hyperglycemia. Post breakfast hyperglycemia, it will definitely be covered. But at the same time, its duration of action is 6 to 8 hours. So it is not sufficient to control. Forget about the 24-hour blood sugar control, but it even not able to control the post lunch hyperglycemia. And that's why one has to administer again the regular insulin 1 hour before the lunch time, and at the same time one has to administer regular insulin 1 hour before the dinner. But even after this, if you just look at the figure, there is a significant fluctuation in the plasma concentration of the insulin. That is again not desirable, because this fluctuation in the plasma concentration of the insulin, it will obviously reflected in the fluctuation in the plasma blood glucose level. And the second biggest limitation, even with these 3 daily injection of the regular insulin, is that it cannot control the interdigestive blood sugar level or basal blood glucose control. And that's why this regular insulin administration is not going to be helpful. So now the next preparation is intermediate acting isopen insulin. Suppose we are giving isopen insulin, it is a somewhat longer acting, so if we are giving it at a breakfast, its duration lasts significantly longer, but at the same time it is having a very slow onset of action, and that's why it cannot control the post breakfast hyperglycemia as well as post lunch hyperglycemia. Fine. So the meal related hyperglycemia, it cannot be controlled even after, if we are giving the isofen insulin twice a day. But if you just look at the figure, it cannot control the food related hyperglycemia. It can only control the interdigestive phase or the basal blood sugar level. So in case of the regular insulin, it can control the postprandial hyperglycemia, while in case of isofen insulin, it can control but not up to the extent that we require, but it can definitely control the basal blood sugar level. Not the ideal way, but still it is one can say that acceptable. But now what to do? Because we want to achieve both, to control the postprandial hyperglycemia and at the same time to manage the basal blood sugar level. So if we are giving the regular and isofen insulin half to 1 hour before the breakfast, what will be the scenario? Here you can see that there is an early peak that of the because of the regular insulin that will cover the post breakfast related hyperglycemia, and as a regular insulin is a shorter acting, but as we are giving isofen insulin, you can see in the slide that amount of the insulin because of the isofen remains in the plasma, which will control not only the post lunch related hyperglycemia, but at the same time it can control the interdigestive blood sugar level. And if we administer the same combination before the dinner, so with this preparation there is a definite control of postprandial hyperglycemia as well as basal blood sugar level, but it is not up to its fullest extent. The reason is that you can see in the slide that this regime is not successfully control the post lunch hyperglycemia. And again, there is no flat insulin concentration in the plasma which is ideally required for the basal blood sugar control, but still it will achieve its purpose up to a significant level. And here what we are doing, that we are giving the two preparation, that's why it is a mixed regime. And what we are doing, we are dividing the total daily dose into the two part, and that's why it is known as a split mixed regime, in which the regular and isofen insulin is administered. Regular insulin is given either as a 30 or the 50%, while the isofen correspondingly as a 70% to 50%. Okay, but if one wants to achieve a tight blood sugar control, because it is very obvious that complications of the diabetes is directly proportionate to the impairment of the blood sugar control. So if one want to prevent the diabetic complications, then there is a requirement of tight blood sugar control, and this can be possible with that if we are adding any ultra short acting insulin analogs like Lispro or Aspart or Glulicin. Here you can see the difference. Here we are not administering the insulin 1 hour before the breakfast. We are giving the insulin analogs just at the time of the meal or even after meal. Why? Because of this the patient compliance is better, and if the patient has changed the time of the food, you can change the time of the insulin administration also. If the patient has changed the amount of the glucose or the food that the patient has consumed, you can change the dose also. That's why the better control is also there, and the patient compliance is also good. And the time at which we require the insulin to control the postprandial hyperglycemia, it is seen with these insulin analogs. So this same analog, it is repeated at the time of the lunch and at the time of dinner. Fine. And what about the basal blood sugar control? For that, as I told you, glargine, which is a long acting insulin, so if you are administering it at a bad time, then it will control the blood sugar level for 24 hours a day. So here is the glargine administration a day before. So here you can see that there is an ideal control of the postprandial blood sugar can be achieved with the Lispro or Aspart or Glulicin, and basal blood sugar level is also controlled with the glargine, and because of the peakless effect of glargine, there are negligible chances of interdigestive hypoglycemia. So this is known as a basal bolus regime. Bolus means before the each meal, breakfast, lunch and dinner, we are giving a bolus dose of insulin in the form of Lispro, Aspart or Glulicin, and basal insulin we are providing in the form of glargine, long acting insulin analog, which is having peakless effect. So this is all about the insulin regimes, their timing of administration, their advantages, their limitations. Okay, so if you are having any doubt, you can definitely ask in the comment box, and if you like this channel, please subscribe it, and that is Pharmacology in Simplified Way by Dr. Darshan Dave, and keep sharing and keep learning.